Hello, everyone, and welcome to edition 2 of Ask Us Anything from the ID co-founders. I'm one of your co-founders. I'm Dr. Kathy Dooley. Very, very proud to be here tonight with two of my favorite people in the universe, one of which is another co-founder, Dr. Folckomer. Take it away.
Hi, guys. Dr. Anna Folckomer. Love this ID family. One of the co-founders along with Kathy and Danny.
Wonderful. Speaking of Danny, co-founder 3.
Hey everyone, Danny here, artist for the seminar series. Happy to be a part and had a really fun time last time, so looking forward to round 2.
We had so much fun.
Yeah.
Anna and Danny and I afterwards, we were just gushing at how much fun it was, and we have to keep this going. So we're gonna do this every Sunday, until this situation of isolation ends. And after we're allowed to do things in person again, we have some fun things in store for you guys that we've been talking about. So we'll keep you baited until then. Hopefully you'll join us on Sundays and we'll have a blast. I've muted all your cameras just to let you know, and we need you to use the chat box down below for you to ask any questions. We're here to answer your questions, but if we unmute your camera, it's going to cause a lot of feedback. So we're just going to try to keep that to a minimum and keep the co-founders on mic. We have a special guest with us tonight. I'm going to unmute her camera because she's one of our teaching team members, and we're very proud that she's joining us tonight. Her name is Karin Ravalese. Karin!
Hey, Kathy, how are you?
Tell them a little bit about yourself, Karin. They know us pretty well, but they need to know you.
Just a normal person, I guess. Yeah, I mean, I've done martial arts for years, just involved in, training, with training myself, and, just had some, aches and pains here and there, or, just trying to be better with my movement. And, I had met you several years ago, and then just through working with you, got involved with ID, taking the courses, fell in love with it, really seeing the difference in my own training. I feel like I've gotten a really good, clear, steps on where to go, how I can kind of optimize myself before I start my workout, just to kind of see where I'm at. And, it's been great. It's been a huge help. And I know you and I have talked about this before. I really don't feel like, it's not specific to just like a clinician, or I think anybody can benefit from ID. Just, you don't have to, take account. It's just really about taking accountability for yourself.
I like that. We're very big on that here, as you know. Thank you so much, Karin, for joining us live. We really appreciate you taking the time to come in. So we'll also ask Karin what she feels about some of the questions that are asked. If you folks have questions, we have some questions that were asked of us digitally, but if you would like to get a question answered, you're going to want to use your chat box, and that's down below to the left of the green icon that says share screen. You're also going to want to use that when we do our little contest for a $50 coupon off of an ID course. So to get to it, we have a couple of really, really great questions, and I know the ID team will be eager to answer them. One of the first ones was on the piriformis muscle versus the obturator internus muscle. And the person asked how to differentiate piriformis and obturator internus causing issues for the person. And I thought that was a pretty fantastic question. And I wanted to pull up the ID manual. And so just give me a second to do that.
It could just be that it's picked.
Okay, so going over to the manual here, we want to show you what we do in macular dissection here and give you a little sneak peek into our manual. So as you can see, this is the ID manual. It's something that we're extremely proud of. The art is, of course, by the amazing Danny Quirk, and the content, of course, is by the three of us. And what we want to show you here, this is the piriformis. Believe it or not everything in your buttock is piriformis. And I love that someone fielded the question how to differentiate between these two, that she actually knew that there was something in their buttock besides piriformis, which was great. So the piriformis muscle, it comes from the sacral ala and mostly from the anterior surface, and it's emanating posteriorly to attach over to the greater trochanter area. Obturator internus doesn't actually originate from the sacrum. And we'll talk about the difference between that in a second. But just take a look really quickly at Danny's label here on the piriformis. Look how small this is. It takes up a very small amount of surface area. And in edition 1 of Ask Us Anything, we did cover about not everything in the butt being piriformis. So I'll let you guys watch that one if you're really wanting to see what all the contents are that are in your buttock. The obturator internus, you can see its origin is quite different. It comes from very anteriorly from the pubic ramus and the obturator membrane, and then it's emanating posteriorly through not the greater sciatic notch like piriformis, but the lesser sciatic notch, meaning that it travels more inferior over to the greater trochanter to attach. Both muscles do serve as external rotators, and they're not power generators, they're joint centrators. We also covered the topic between the difference between force generators and joint centrators on the last Ask Us Anything, so you want to check that out on YouTube. But when we do an immaculate dissection is we help people locate bony landmarks for palpation. The bony landmarks are actually pretty crucial. We orient people around the ischial spine to be able to locate obturator internus. And then for piriformis, we actually encourage them to look at the PIIS, a landmark that's below the PSIS, and then the superior aspect of the greater sciatic notch that you see here. And so we use palpation as if we can, and tightness towards those areas of palpation when we can. And then we also use what are called clinical pearls. And clinical pearls, and then just to give you a sneak peek of our ID manual, we put them on every single structure. We work really hard to make sure that part of your diagnostics are related upon clinical pearls. Clinical pearls of piriformis can include things like sciatic neuropathy. Obturator internus very rarely gives you that. Obturator internus instead is basically related to pelvic floor. And we'll talk about it more later when we cover a pelvic floor question. But obturator internus is very, very connected to your ability to contain the lower part of intra-abdominal pressure. And it's not through the muscle itself, but the fascia that covers it and that the muscle co-inserts into. I know we'll piggyback a little bit more on that later, but pelvic floor signs are very common with obturator internus and not common with piriformis as much. So I'm not saying they can't coincide, but we're always looking in immaculate dissection at what the tightest, most dysfunctional structures are and associated with these clinical pearls and then associated with assessment. In immaculate dissection, we also cover joint centration is a very, very big deal. These two muscles, as you saw, are extremely short and they're one joint muscles, which means they are trying to center you in the socket and prevent you from going outside of a certain mechanoreceptive range that can keep you stable over your center of effect. Dr. Folckomer, can I default to you on adding some of your amazing pearls?
Yeah, so this question, you kind of hear this question repeated in ID 1 and 2 a little bit. There's, if you combining the skill sets, it's always really nice when, combining the skill sets of each level becomes sort of this cumulative clinical approach, right? So, we give this really nice kind of extra little rotational test in ID 1 to determine, this pelvic floor involvement, if it is actually leaking over into the hip. But then in ID 2, I say this because there's 20 people on this call, but I have a secret. ID 2 is my favorite.
It's my favorite too. We don't even make it a secret.
No, it's fine. Yeah. It's my freaking favorite because it is a foolproof system. Guys, it is like following a recipe. I love to cook. So this is like a clinical recipe for success of, all right, I've got this test to determine, really narrow down which region, not only which region is the most problematic, but which plane is the most problematic. And so once you start to really focus in on the hip, and then we're looking at, the possibility of rotation as being part of the problem in this clinical presentation, now we can hone in on it with the clinical pearls and with the tightness and the palpation that is very, very, very straightforward. There are plenty of pictures of my butt on the internet with stickers on it. Because we've really refined this. And so, the pelvic floor kind of leaking into potential joint centration rotational issues is something that's really nicely illustrated in ID1, but then also how to have really sharp palpation skills, because yes, there is a palpable difference in piriformis and obturator internus. It doesn't have to be this sort of amalgamous mass in the butt of like, maybe this is it, or I'm going to sort of, by a confirmation bias, I'm going to call it piriformis because I'm roughly in the butt and piriformis is like sometimes a problem. So let's just say, yeah, sure, why not? I like piriformis, right? So many people practice like this sometimes. And so this, the ID2 skill set really sort of helps you hash out the butt cheek, really. And you've got stickers as landmarks. You've got palpation of, no, this is definitely piriformis, this is definitely obturator internus, and then accompanying signs and symptoms to confirm it. And so as you kind of dive in further and further into ID2 skill set, it's just confirmation after confirmation after confirmation after confirmation that you are in fact going after the right thing. And that if you get to a certain point where you're just like, hold on a second, that doesn't quite add up, there's, you know, you can always step one step back and then, oh, that's what I missed. So I think it's just illustrated beautifully. I really like the roadmap that ID2 falls under, because there's something so fulfilling about taking this massive, it's a huge freaking manual. Like it's a massive amount of information and actually summing it up to a couple of really straightforward assessments. And I mean, you'll get it every single time. I mean, it's just, you can't go wrong if you follow these roadmaps and stuff that we've worked really hard to lay out for you. So.
Yep, it's really, I think that's why, I don't know, I can't speak for you, Dr. Folckomer, but for me, I think I like ID so much because people are so confused when they get to ID2 about a knee symptom, a foot symptom, a hip symptom, and the difference between those symptoms and where the problem actually is. And I think that ID clears that up really nicely in ID2. Danny, what can you share with us about how you feel about differentiating piriformis and obturator internus?
Well, just kind of, I mean, like it helps a lot though, kind of doing a series of tests and a series of movements to differentiate which muscle is in essence the culprit. So, you know, so through doing a series, I mean, obviously both of these are going to be working in the external rotation and whatnot. And through doing a series of guided movements and guided palpations, you know, we can really differentiate as to which muscle is causing the problems, which ones aren't. And when you have so much anatomy and so many things that are happening in the same general area, having a test and having a protocol like that to work under really helps to eliminate all these things and kind of focus and hone in on one particular structure.
Absolutely. Very good. Karin, do you have anything to add as a teaching team member?
You know, just the same thing too, is like the clinical pearls, and then just like the step-by-step process. You know, you're always, I know we're talking about ID2 right now, but, you know, making sure like what the intrinsics are doing first, and then do you even have permission to be into the lower extremity? So I like that. Like, I feel that ID really fortifies that and has a really good, clear cut way of going about that, and knowing like, are you really where you should be? You know, like, you're not going to start doing like a certain like movement test if you haven't cleared like other higher priority areas. So that's what I really find helpful with ID.
Awesome.
Been awesome. You know.
Also, I want to shout out to Danny too, just in terms of, you know, the palpable differences between a lot of these things. When Danny's painting, he uses the same palpation techniques that we use in class clinically to really refine and make his artwork as accurate as possible. So he's not just, you know, it might be late at night and he might have been painting for like 12 hours straight, but he doesn't just go, blah, 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 butt cheek, there it is. He's like checking and, you know, checking with rotation and checking with palpation and doing little muscle tests to make sure that everything is in fact lining up and that what he's painting is genuinely accurate. And I have seen him do that for, you know, 6 years now, like anywhere from 20 to 40 times a year. So, I mean, he's definitely practicing what he preaches there. And it shows up, you know, that these are the most accurate ways to find these specific muscles, even when they're that small and shoved in such a small surface area.
Well, and to piggyback on that as well, I mean, obviously this seminar course is, you know, it's movement based, palpation based, so on and so forth, but obviously not having quite the same background as you guys, like, you know, the clinical applications, so on and so forth, where the role kind of comes into play is creating these, in essence, visual palpations. So kind of by putting through you know, what's taught in the seminar, putting into motion, doing the palpations on you, feeling them on you, can at least have the confidence that things are lining up, you know, where they are. So
to piggyback on that too, the person that was asking the question said, what can you do besides palpation? And I think they're a trainer, and I think that palpation is only a piece of what we do in immaculate dissection. We actually ask the client, where is your tightness? And then marry that to our assessment, marry that to our clinical pearls, marry that to our dysfunctional movement screens and assessments. So it's not just palpation. It can't ever be just palpation.
Right.
It's always a combination of 4 major criteria that we follow in immaculate dissection should you choose to take the coursework. All right. Moving on to the next question, a really, really good one. The person was asking about hip hinging. She had come to the Immaculate Dissection 2 course, and she was asking about why it's so important to maintain the IDQs on a hip hinge, and how the IDQs actually carry over into a hinge. So let me do a screen share and just show you what we mean by a hip hinge. And most people know this as a deadlift, or like a position where you're not squatting. If you're understanding the difference between squatting and hinging, hinging is typically referring to the deadlift position where the tibia do not translate excessively forward. This keeps the foot in relative pronation versus an anteriorly translating tibia, which will encourage more supination, especially when it's coupled with external rotation of the tibia. So in a hinge position, as you can see Dr. Anna here in the manual, she's using a stick, and that's to maintain her IDQs. Neck long and back, chin back, chest wide, ribs down, and then ASI is PSI is relatively even. We say relatively even because when you're standing, the weight bearing effect will naturally pull your pelvis into a tiny bit of anterior tilt. What we mean by all these cues is that we're trying to maintain cervical and lumbar lordoses, and we're trying to maintain the kyphosis of the thorax and sacral areas. And by doing that, you preserve the ability to compress axially against gravity and ground force contact. So you're saving the spine, which is our first priority in all immaculate dissection coursework. So through the preservation of that, we actually use a stick that contacts the external occipital protuberance, the back of the skull, so the back of your head, in between Dr. Anna's shoulder blades, so that she's maintaining her kyphosis. If there's any space here, we know that's not good. She's losing her kyphosis. And then keeping this right in the center of her buttocks so that she's maintaining sacral kyphosis. So we're maintaining cranial position, maintaining thoracic kyphosis, maintaining the sacral kyphosis. And we're maintaining our lordoses, of course, because they're not touching, right? Because lordosis by definition is movement forward, and then kyphosis movement backwards, anterior to posterior. And then you can see Dr. Anna, she projects her hips backwards, not quite at 9 o'clock, but about at 8 o'clock on an analog clock. If this is 6 o'clock, this is 8 o'clock. So a squat would be straight down, but Anna's going back more. And that's keeping her tibia relatively straight, keeping a relative pronation as she sits, and putting more emphasis on the posterior chain. That's different than the squat, which will put more emphasis on Dr. Anna's quads and anterior compartment. So why is it so crucial to maintain this stick with or without the stick? And that's the big question. So to partially answer it on my end is that nothing is worth doing if you're sacrificing the spine. So if you choose to hinge on a regular basis without stabilizing the spine, you're going to experience some trouble, because remember that posterior chain mediated event is dependent upon L4, L5, S1. If you're changing lumbar lordoses, thoracic kyphoses, cervical lordoses, and by all means sacral kyphosis, then you could alter the neurological and circulatory supply through that greater and lesser sciatic foramina that are not only centrating the femur, but innervating your power generators, gluteus maximus and hamstrings. So why would you ever do a hinge where you sacrifice your spine? It makes no sense. You will pay the piper, and that piper could be even discogenic back pain, sciatica, neural tension, and it basically will result in you not being able to lift. And I know you guys don't lift to not be able to lift. You didn't come this far to come this far. You are maintaining the spinal positions always. And if you have to limit the amount of weight or depth or modify the hinge, then you do it, because nothing is worth sacrificing the IDQs. Anna, you want to take it from here?
Yeah, and I think that that's one of the things that's so great about the dowel, because we use the dowel a couple of times throughout the course of ID1 and ID2 to really make sure that it's not only to set the person up for success, but it's also to keep them safe and to show people, you know, I move away from that dowel. Here's a little vulnerability for me. And so I think that what it's great about showing is it provides this sort of juxtaposed visual of seeing what moves first, because people that think that they're moving through their hips first may not. They may be losing that lumbar lordosis first, or, you know, rounding a little bit, and it might be something that they've done 1,000 times and, you know, that never had any discomfort or whatever, until you start to put that dowel on there, and then it's like, oh my God. So there's something that's very honest about it, because it's a huge safety mechanism, and it shows that, well, if your lumbar spine is moving first, then that's going to continue to probably be the more moving thing, because now the hip has to sort of fixate, and that's going to be, if you're talking about going under load with that, that's an area that's going to be really unsafe for the client. So, you know, and it's always interesting when people seem to find this position the most when they absolutely have to. Like, I know are practicing telehealth right now, and I had a patient that sort of threw her back out because she had groceries delivered and she was picking them up and stuff, and not in a hip hinge, but in, you know, loss of cues and things like that. And so now she's saying, like, she's exploring this hip hinge now more than ever because she doesn't have any other choice. So it's this interesting thing that people, you know, do end up sort of finding it, but the dowel usage is a really nice way of finding that kind of right then and there, but also minutely fine tuning it.
I love that you said that, Anna. The dowel is very enlightening and very humbling. You put that dowel on people and their toes start to come off the ground. And we talk to them about losing the tripod of stability into the foot, and how that can be a pretty big problem, and how people are even coached into lifting their toes to shift that weight back. And so we're really excited for you guys to learn, either online or in person, some of the ID stuff of the way that we cue the lower extremity. And the dowel, man, is it a humbler. Danny, what do you think about the hip hinge? What can you add to this?
Well, I was going to say, kind of playing off that notion right there, like it can be pretty overwhelming looking at everything happening all together at once. So, you know, if you, you know, see a body trying to get into a movement and whatnot, you know, it can be looking at tons of things all together at once. And again, I think kind of having that dowel on there, I think having kind of that aspect on there, it kind of shows what a more proper alignment and proper movement should be, kind of focusing on what should be going on. So, like, I guess kind of an example from world here, like, you know, like, try to replicate a color, try to replicate something, we'll use a thing called an aperture. And the aperture is a way of isolating, you know, said color, said structure from everything else in the entire piece, and allows for, you know, just like a nice focus in that one particular area. And, you know, if you start implementing aspects like, you know, the dowel or so on and so forth, you can really focus on the areas that may have been overlooked in terms of improper movement or improper cueing, because it's focusing the eyes on this one area that's really going to create the most important aspect of that spinal stability.
That is awesome. Yeah. That's a great analogy. Karin, do you have anything to add about the hip hinge?
You know, just the IDQs. I feel like if you can maintain the IDQs, you know, you're just going to be, you know, better off with any motion that you're doing. You know, because then you're going to get away from, you know, like a mimicry type of thing, like you're copying what someone's doing or what you perceive to be the actual movement. You know, as far as like you have the illusion of maybe going back, but your hips really aren't going back. So if you maintain the IDQs, you know, you're safe. You're going to put yourself in a really good position. And if you can't, you know, go all the way back, and, you know, it's like you're self-monitoring yourself, which I think is really, really huge, because someone can tell you to your blue in the face how to do something, but if you can't like really feel it yourself as you're doing something, then it's it's really difficult to get someone to understand it. So I think the IDQs they're just really great. They're helping you find it for yourself.
Awesome. Yeah, we're pretty big on them, as you guys know, that have taken the courses. And if you haven't, we're going to make you say it constantly: neck long, chin tuck, chest wide, ribs down, ASI is PSI is relatively even. It's a mantra of sorts, but most importantly, it is a Bible for us, non-negotiable, a law and not a theory in ID world. Okay, I'd like to take a question from the gallery here. The amazing Gurinder has asked a great question. I'll read it to you guys. What areas of the body provide the most sensory input that when we cue automatically help improve uprighting, load sharing of the spine? Well, I think we covered that. Neck long, chin tuck, chest wide, ribs down. ASI is PSI is relatively even. Those are why we cue where we cue, because they have the most proprioceptive ridge fibers. So there's that part. Sorry to be a broken record there, but it is what it is. He added, I find cueing the hands and feet produce a feedback. Of course, hands and feet don't come first, though. Hands and feet are innervated by the spine. And so if you don't cue the spine first, you can compress the spine. Let me give you an example. If someone's caught in like an anterior head carriage and they slam down C7 to T1, it's going to be really hard to cue their fingers if their CT junction is jamming, because you're creating neural tension down the pathways to what innervate the hand. C6, C7, I won't flip in traffic, and then 8, right? Those C8 nerve roots. So be careful cueing the feet and hands before you cue the spine. So you can do neck long, chin tuck, chest wide, ribs down, ASI is PSI is relatively even. And of course, we cue the tripod of the hands, which is, if Kirby were here, he's DNS all the way. He's A through D, and he talks about the neural development of the child and focusing on the palmar aspect of the 5th digit first, because that's what you develop first. Ironically, it's the smallest finger, but has the most amount of motor control for your shoulder. The second place between the 2nd and 3rd digit, and then at the base of the thumb. And the same thing is true for the bottom of your foot. The anterior part of the calcaneus, the 1st met head, and then the 5th met head. And so we call these the tripods. And yes, we do cue those. We wouldn't cue them before the IDQs. They're not considered IDQs of spinal stability. They're IDQs of tripod stability for scapulothoracic joint, for the pelvis, femorotibial joint. They are important. I'm not going to denote they're important. But you can't cue everything, folks. Mm-hmm. And you want things to be as reflexive as possible. So as you're training neck long, chin tuck, chest wide, ribs down, hips even, and cueing the hand and foot tripod, you're pretty golden. Those are pretty proprioceptive rich areas, although if we're going to play that game of proprioception, woo, there's a lot of rich areas. It really depends on what the person's doing and the task execution. Anna, do you want to add anything to that?
Well, actually, I want to piggyback and kind of combine that with the last question about the dowel, because what you see a lot of time, it's revealed over and over and over again with like amazing athletes that take the class. When we put the dowel up there, it starts to make sense why they feel like maybe a barbell or something slips from them, or why they can't wrap their pinky fingers around the bar or something like that, because the spinal positioning is going to, just like Kathy said, really affect the proprioception of the hands. And so we do have to prioritize those spinal cues in efforts to just get good feedback from the hands, because if you don't have the spinal cues, you don't have that sort of basic setup for success and safety, doesn't matter anyways. And so when we start to really illustrate that with this visual rod, literally, and you start to see the position that someone comes apart first, all of a sudden it's like these light bulbs go off, and not only can you see them, you can literally just like hear them in the room. Everybody's heads exploding of just like, oh my God, that's why I can do, this grip, but not this grip, or that's why I always lose my pinky finger here, or that's why I'm better at gripping my thumb here. And so it really does sort of feed back to that same thing that we were just talking about in terms of using a visual object to really refine those cues.
Yeah, I want to add to, not only did very eloquent Dr. Folckomer, you can't forget too that you have a cervical and lumbar spinal cord enlargement. right? You have a brachial plexus and you have a lumbosacral plexus. So if you don't cue the neck long, chin tuck, chest wide, ribs down, ASIs, PSS relatively even, you're going to miss the mark on the vast majority of proprioception supplied to the area. Now, we do add in the chin back, not just for the cervical lordosis, but to keep your jaw in check, because your jaw per surface area has the most amount of proprioception, position sensing. So we do want to keep that in check, and we cover that in ID4. Danny, do you have anything to add?
I mean, it's all just going to stem down to a platform of stability. If you're not stable from like the innermost portion, everything else is going to systematically fail as things go on from down there, or not be quite as stable as should be. So if again, like if kind of don't necessarily have that spinal stability and cueing arms, cueing feet, cueing so on and so forth, it's building off of a faulty foundation to begin with. And compensation patterns can get you so far for so long, but come the end of the day, it's not going to allow for proper anything moving forward.
Yeah, we go into a lot of detail on the neurology of sensation in ID5. So if you guys are really wanting to dive into neurology, we do these really nice pre-course videos beforehand to teach you about what somatic afference is versus visceral afference, visceral efference, somatic efference, autonomics. We definitely want you to understand the differences between sensory inputs. We cover it in really nice detail. So if you're wanting to dive in and really understand things, we break down every peripheral nerve pathway. We go into quite a bit of detail in ID5. That's peripheral nerve concepts. So you can do that online or in person. I'm going to move us along really quickly because I see that we've already got a half an hour in. Wow, and we'll only answer 2 questions. So I want to do another question from the gallery. We had a really nice question. Let me see if I can scroll down here. We had a question from Martha. Hi, Martha. Martha's taken a couple of our courses. She's an amazing student, and we're just really proud to know her. She asks, can you explain visceral somatic reflexes? For example, if T8 gets somatic afference, how it locks up. So visceral somatic reflex is a type of referred pain that occurs through sensory awareness that happens in peripheral nerves. So for instance, I'll give you an example. You gave T8 as an example. So T8 supplies parts of the parietal peritoneum that give feedback into its connective tissue, right? That covers the liver, covers blood vessels, and particularly the inferior vena cava area that goes through the thoracic diaphragm at T8, which is, I'm assuming why she brought this up, because she's taken ID1. And when this happens, when the diaphragm gets tight around the inferior vena caval hiatus, which is close to the central tendon of the diaphragm, what will end up happening is venous stasis through the inferior vena cava, and that backup can then encourage visceral afference. Visceral afference is just like putting pressure on your arm. You can have pressure on vessels too, and that pressure from the vessels goes into the spinal cord at the same level as the somatics do. And so you start to get this crosstalk through interneuronal activity at the spinal cord level, and then you get a somatic response. And the somatic response can be things that are innervated at the same area. And since the parietal peritoneum that's underneath the thoracic diaphragm is the same innervation as the inferior vena cava, as do the somatic structures at T8, like spinal extensors, you end up getting a somatic response that is because of visceral action at the spinal cord level. This results for us in immaculate dissection 1 as a T8 lockup, which basically means the thoracic spine at T8 level feels very tight upon palpation, or the client complains that the person, that they feel like they constantly need to be adjusted there, or they need to foam roll there. And we match that to our clinical pearls and through our anatomy of studying the thoracic diaphragm in that visceral somatic reflex to then see if we can change it. And what we do is use the somatic system to change the visceral input, which usually is a pretty great thing. It's so effective, folks, that I have to watch as a chiropractor for red flags. Like if someone is giving me constant low back pain from an abdominal aortic aneurysm, right? And I don't know that they have an aneurysm, but they are over the age of 50 and a smoker and overweight and hypertensive, and I'm constantly constantly adjusting their lumbar spine and giving them temporary relief, because that's what motion does. Mechanoreception is much faster than pain reception. And they could eventually blow that aneurysm because I was shutting down their visceral afferents through the somatic system. That's how powerful it is, that I had to do 5 years of education to make sure I didn't kill someone with my adjustment. Not that my adjustment would kill someone. It was that the fact that I ignored the visceral somatic reflex. And so we never ignore the visceral somatic reflex in immaculate dissection. And so we have our fun little mnemonics, our songs that we do for the diaphragm. It's I ate 10 eggs at 12. I know Martha can tell me what that means. It's all about visceral somatic reflexes, how the viscera can play a part in our somatic structures like spinal erectors. Anna, you want to piggyback on it?
Yeah, it's not, you don't have to, it's really not that hard of a reach to make all of this become extremely holistic. And I know that we spend a fair amount of time in ID1 talking about that with the, just sort of the spinal segments as part of our intake, and also, as it relates to diaphragmatic clinical pearls. And then again, we actually revisit some of this a little bit with ID5 and just referred organ pain, and really being able to kind of hash out what is the nature of this discomfort, what is the narrative behind the discomfort, and how to be, as wide angle lens and as holistic as possible, so that the person who is coming to us for help has the most success. And I spoke with a patient in an acute situation last night pretty late who thought that the world was coming to an end because he had all of these signs and symptoms, and it was back pain and a lot of indigestion and things like that. And it was like, help, I'm falling apart, I'm breaking. And it was, this sort of grab bag of symptoms that, to some people might kind of sound all over the place. But then when you really are able to take a step back and view this holistically, it's like, oh, no, that's actually, this is that referred pain, this is that viscerosomatic reflex. And one of the things that was so interesting is he kept trying to kind of crank into his back. And he was like, I'm so mad I don't have a foam roller. And I'm like, it's okay. You don't have to, because he was like, but I don't know what to do. I've got a back problem and I got a stomach problem. I'm like, no, let's talk about it. I think that this is a really nice way of being able to thread together your whole storyline, your whole patient's narrative, and then be able to go after the highest priority things so that you can observe the success of literally a clinical trickle down effect of, all of these other things kind of sorting themselves out, because turns out they were all related. And if you have the skill set to be able to go in there and kind of get that highest ranked priority, and obviously explain to your patient that you don't have to let me fix this, let me fix this, let me fix this, let me fix this. And I think that the viscerosomatic reflex is a really, really great way of making some magic happen from a holistic perspective with your clients and patients, for sure.
I love it. I love the fact that, he was like, oh God, somebody just moved me at T10. And you're like, oh, don't worry. It's viscerosomatic reflex from your stomach problem, your GERD, your indigestion. I love it. I love when we can help people stay calm about something that feels serious, or maybe they don't even relate their back pain to their stomach issue, and viscerosomatic reflexing is the way to do it. Martha, hopefully that answers your question pretty well. Danny, do you have anything to add?
I mean, just in terms of just kind of chiming in a little bit though, if you can get certain things that double an effect or double a symptom or not, by being able to have things like clinical pearls, or being able to have things that kind of teach you to differentiate and understand the difference between what something feels like and what's actually happening on the inside, it can allow for more of a proper, effective means of treating things.
Oh, that's lovely. Yeah, I really agree with that. That's awesome. Karin, do you have anything to add about viscerosomatic reflexes?
No, just the same. I like what Anna was saying about the holistic approach. I think that's great, and we can get away from that. And this kind of gives us, the answer. You can really learn a lot when you start studying anatomy.
Awesome.
Things, the blinders start to come off.
Yes, I think that's very true. Good. So let's answer another question that we had, a digital question. I think it's a really, really good one. Someone had asked the difference between flexibility and mobility. And they brought up the fact that I had posted something today about Australian dancers are being discouraged from static stretching. And it started a really nice discussion about, like, someone was, mentioning like, oh, I stretch and it feels great. And I go, that's wonderful. It feels great until it doesn't.
Yeah.
And I didn't mean to be antagonizing. I was just saying that was the way it worked for me. It felt great until it didn't, because there's a big difference between flexibility, which is very common in dancers, and stability with this motor controlled mobility. Mobility and stability are not the same. And the biggest difference that we talk about in macular dissection is flexibility indicates that there's connective tissue softness. The soft tissues are pliable. It's a passive thing. Flexibility is passive. Mobility is the ability to control range of motion with a stable platform. And for us, it's a trifecta in immaculate dissection of mobility, stability, and strength. You got those, you've got load share, you've got spinal protection, then you're not going to have very many limitations. And it's the difference between a dancer lasting many, many years and a dancer lasting 10 years. Now, I've got to default to the amazing Dr. Folckomer, who is a very, very well-trained dancer. Amongst her, she's like a Renaissance woman. She's got so many skills. But this woman has a ton of training and treats a lot of dancers. And Anna knows, of all people, the difference between flexibility and mobility. Anna, can you share?
Where do you start with this question? I love it so much. I think that, there's a lot of different types of athletics, dance certainly being one, that sort of celebrates this idea and this theme of being flexible. But it's only a puzzle piece, right? Because often you're sacrificing something to even get that flexibility, and there's no talk of extensibility whatsoever, right? We've all stretched something and then had it snap. I mean, like my hair, my God, if you had any idea how many hair ties I've been through, because they all have lost their extensibility. And I think about this every time there goes another one, like one more ponytail is just gone. I'm going to look like crap today because my hair is all over the place because I've snapped another hair tie. I think about that and how it relates to so many injuries I've had that were just stretch until one day, it's just like a hair tie that's just done. And so I think that the conversations of flexibility really should be sprinkled with extensibility talks, elasticity as well. But also does the stability grant you the permission to explore those ranges of motion? Because it might not be the stability that's giving you that permission. It might just be a performance request that's giving you that semi-permission of just like, well, you know what, this is where your paycheck's coming from this week in terms of the ability to perform this range of motion. And that's different. It's not to invalidate that at all. It's just to say that, that's a sort of different set of rules that we're sort of adhering to. And so my goal is always to sort of help people so that they have, as much permission as they're going to get, because there are people put on this world who do amazing things, and then they do it because their heart literally won't let them do anything else. And I'm not here to take that away from anybody, but we can follow these sort of biomechanical rules in terms of how to get people doing all the things that they really do feel like they're on this earth to do in the safest way possible. And that's where, your exercises, your rehab, your correctives may look a little less range of motion-y, but they're ultimately giving you the permission to be able to go and perform and do all of the things. We're talking about hamstring tears. We're talking about, people that have just avulsed tendons off of all sorts of bones in their body, definitely not just limited to hamstrings, strains of every single kind. And helping somebody understand the sort of etiology of why they got injured in the first place helps them recover a lot faster from it. Because so often people will tap into that sense of awareness that they have. And, an oblique strain or something, what is that person going to do? They're going to stretch, they're going to stretch, they're going to stretch. Hamstring strain, they're going to stretch, they're going to stretch, they're going to stretch. and you're compromising, you know, you'll never forget it. Think about all of my hair ties and what they've been through. It's like, you know, those little pieces of elastic that start to fray out of it. And so you don't want to be pushing yourself one step further into the wrong direction of being able to recover from something, so you can go back to doing what you want to do and what your heart and your soul needs you to do. And something I feel really, really passionate about, and just in terms of the education, but also the organization of goals and the organization of, like, I do this because of this, and on another day I do this because of this, and it is possible for them to coexist. So yeah, you know, I think dance is just one of those many sports that you see this recurring theme in, but I know that it's not limited to dance. And
No way.
I think a lot of people, especially as clinicians, we've seen a lot of this. So
People
yeah.
stretch because it feels good, right?
Yeah, of course.
Stretch, it feels so good. Let me tell you where stretching, when you don't have the right to do it, gets you. It gets you like what I did, a major hamstring strain that Anna was talking about. As a distance runner, my hamstring, right hamstring, always tight, tight, tight. If it's tight, I had to stretch it. I stretched it to the point of near rupture. You know, it felt good because it's an activity that, you know, encourages blood in a lot of cases. And I think that without assessment, it can be as dangerous as it is helpful. And at first it did work for me. It was helpful, and then it wasn't. And so in immaculate dissection, we don't use stretches. We use these movements called pendulums, which we described in episode 1 of Ask Us Anything. These movements that are controlled mobility, right? Stability motor control training under a stable platform. We're moving. That's stability and mobility. And then once the person has that, we build strength on top of it, right? So that is it was a really good question. I really was so glad that someone asked, because I think it's a really pertinent one. Danny, you have anything to add?
Well, I mean, I would just say is on top of that, though, you know, just because something can move or can do something doesn't mean that it should. So like, you know, I mean, we'll talk about it a little bit in the seminars, you know, kind of as a visual there, but, you know, like, say example, things like little paper clips, you know, like they're relatively stable. They, you know, they do whatever else, but they also have the ability to move. And, you know, you move that and you move that and you move that enough. And yes, it gets you through certain movements. Yes, it's able to move around enough times, but, you know, you do it enough and that happens, you know, like it eventually reaches a breaking point, and that's when you get your injuries. That's when you get your whatever else. And again, kind of playing off the pendulums and playing off whatever else, like, you know, you can do a movement, but if the joint's not designed to do said movement, it's going to put it into that range of, you know, injury and that range of being hurt. So by taking the pendulums or putting, you know, the joints, the muscle structures through their proper range of movement, proper range that, you know, allows that first, that stability, allows for that amount of range of motion where it's not harming or hurting things, that's going to build that stable platform to allow you to move systematically a lot healthier and a lot more efficiently.
100%. I love it. Now I got to default to Karin, because man, you're a 4th-degree black belt in Taekwondo, and it is very encouraged to static stretch in martial arts. And you guys are applauded for how high your kicks are.
Exactly. And I'll be honest with you, Kathy, I don't do any stretching at all. I do the ID pendulums and, you know, just work on, you know, the breathing exercises, supine 90, prone breathing, and, you know, progressions off of that. And I honest to God, it sounds crazy, but I really don't stretch anymore. And I feel like my kicks are better. And, you know, I'm not really all that concerned about trying to, you know, kick like as high as I could possibly kick. If, you know, as far as being like, we're talking about flexibility here and stuff, like I feel that I have plenty of range of motion, but in essence, can I really control the range of motion that I have? And to me, that's the big takeaway. And that's what's most important. So it's like, work with what you have, you know, work on trying to build that, because, you know, as we say it, you know, what good is it if you can't control it? Because then you're really going to set yourself up, you know, for injury. And if you keep trying to like do all these stretches and, you know, trying to like lift your leg up in the air or mobilize your hip, it's like, you know, the hip's not the problem. The problem is the core stability, and work on that. And then you'll have all the mobility in the world of your hip, you know, your shoulder, your neck. That's what I found. So
good. Thank you so much. I can't get over like the fact that stretching works until it doesn't, man. It really is a short-term mobility strategy, a short-term mobility strategy. It's not going to give you the lasting results unless you combine it with stability. And so you can be flexible and not stable, which is a lot of dancers I've treated, a lot of people that I've treated, is not just dancers. And then, for a while, they were good and they could always touch their toes. And then one day they couldn't touch their toes anymore and they were wondering why. Like, oh, I'm not flexible anymore. Are you? I think that maybe you were too flexible on one spot, like Danny was describing, and didn't have the ability to stabilize. And so that's when if you start sacrificing mobility for stability, it's going to be a problem. So I love that the person asked that question. It was really, really good. We had another question from the gallery. We're getting to as much of these as we can, guys. These are awesome questions. Ruby asks, one thing I encountered in my climbing gym is a high degree of elbow tendonitis. Does the upper extremity course cover assessments and solutions of variations in this issue? Yeah, we actually teach you that most elbow problems aren't elbow problems at all. That an elbow symptom is usually a problem at the scapulothoracic joint, which includes the neck, the acromioclavicular or sternoclavicular joint, STSCAC joint problems. And you also have to clear them for having a sclerotome issue, because sclerotomes from the spine, they actually refer down to the elbow. So you start, especially with climbing athletes, a lot of them, have, some of them have some grip problems and they have some neck problems. And so they're hanging on trying to strengthen up their intrinsic hand. And then they start to put excessive weight on the elbow joints because they have an STSCAC joint problem. And so we cover that in very good detail in ID 3, which is, I think, a great course. Another question from Michelle, which I thought was excellent. I was wondering if this is a possibility. I found if external rotation tested in supine with Hipaa 90 degrees flexion would be somewhat limited, but in prone, the internal rotation is very limited. Well, I'm gonna solve that mystery for you in just a few sentences. You can't test external rotation in a prone or in a supine position with the hip at 90. When the femur is at 90, the femur is kind of jammed in the acetabulum, and now the hip external rotators become abductors. So if you're wanting to test external rotation, you need to do that prone. We show you this at ID2 on Anna and then on each other, that we do muscle testing that also helps us to differentiate the different muscles on palpation. But also with their actions. And we show you to always test external rotation in a prone position. That way you're not jamming the femur in the acetabulum with the flexing hip. And then once the hip is flexing, you're knocking out a lot of the structures that can, pull you into a good range of motion for external rotation. So really all the P-go-go-Q, like piriformis, obturator, internus, gemellus muscles, obturator muscles, those muscles become abductors once the hip is flexing. So the only exception is quadratus femoris. It's too inferior. So you might want to do your testing for internal and external rotation in a prone position. Don't, you're changing the entire biomechanics once the hip is flexing. So another one, and maybe Anna, I'm sorry to hog the mic here. Anna, you want to answer this one? A good question on cervical alignment. Is a forward tilted head as problematic as excessive neck extension for phrenic nerve communication to the diaphragm? Anna actually teaches this segment, so I think she should answer it.
Yeah, I mean, this is, this is really important to look at, because either way, it's not even load share. And so when we talk about, keeping the foramen nice and patent so that the phrenic nerve can actually fire the diaphragm, it's not going to matter. I mean, the cervical spine is obviously a lordotic curve, and you want even load share of lordosis. So losing your lordosis versus only having, one spot, kind of like Danny just showed with his paperclip, either way, you still don't have that afferents going down, or efferents rather, from the phrenic nerve. And so this is going to be the point at which we talk about the IDQs and why they are the way that they are, because the 4 IDQs actually are a nice system of checks and balances to, keep that spinal curvature in the appropriate spot. You earned that curve. And also, if somebody's hinging on one spot with a lordosis, then you have to start to look at, okay, well, what is their thoracic spine doing? Are they actually flattening out, or have they not only lost their lordosis, you know, across those 7 spinal segments, but are they also losing their kyphosis in the adjacent spinal segments below that, which is, you know, when people start to get those dowager humps and they have to start to crank back in their neck, which it's still not good, proper lordosis. So we don't just look at the one spot, because we see that, you know, when somebody loses one spinal segment, the others are pretty sure to follow. And so when we have neck long, it's paired with chin back, because so many people will try to do something like this. So the chin back is to help maintain load share, because the IDQs set you up for the success with, you know, hopefully working with the spinal cues that you have, you know, what your normal is, but then they sort of keep you from falling too much in either direction. So, you know, no, excessive extension isn't necessarily better than excessive flexion or anything like that. It's just neither one of them is load share, and your chances at being able to communicate with the whole rest of the spine have really kind of like gone down the toilet. So, you know, it does act as a nice series of checks and balances there. You wouldn't want to trade one for the other, for sure.
I love that you said that, and Anna does such a great job of making sure that the neck cues don't impede upon phrenic nerve, because if someone starts hinging, like Anna's saying, like the chin goes up, you're going to compress the C3, C4, C5 vertebral areas, those foramina through which the phrenic nerve's roots pass, and major spinal level C4. So you don't want someone hinging at C4. You want that neck long chin tucked. And that has a major play on, you know, down at your diaphragm, which runs the show for intra-abdominal pressure. So she does such a great job of teaching that at ID1. I hope you guys are able to join us either online or in person for ID1. Another fantastic question, I'll make sure I didn't lose it. Jen asks, if you're just starting out on your own with a healthy movement, is it best to just QQQ? Is there a good starting movement, the hip hinge versus the squat? Oh my God, do not start with the squat nor the hip hinge. In Immaculate Dissection, we talk about no one has permission to squat nor hinge until they get a bilateral, generally symmetrical lunge. And we spend 14 hours coaching you through femoral centration so that you have the permission to lunge. Think about how many people hate lunging. They will squat over lunging any day of the week. Why is that? Because, you know, squatting, you know, you get both legs in the same plane doing the same thing. Squatting and hinging are important to life. You do each probably around 10 or 15 times a day between picking up things off the floor and pooping and peeing, right? And maybe, you know, some sex if things get randy, right? Depending on what you prefer. But that noted, you tend to walk when we're not in isolation, you know, 10,000 steps a day, and each one of those involves a lunge. So you might want to prioritize your lunge. And so when you take ID2 with us, we're going to stabilize your core first, and then we're going to put you through progressions of femoral centration. And I suggest you, if you don't do telehealth with one of us, that you take the courses for yourself and put it into your own body, which would be a genius way to learn this stuff. 15 hours of instruction, and then you get the goal of putting it into yourself. You follow it step by step, and you'll know what to do for yourself. And we're all about self-empowerment in ID. We don't want you to be our patients. We love that about you. You're welcome to hire us. We want you to help yourself as often as possible. So if you're an attendee for our course, we give you a person to work with the entire weekend so you can figure yourself out and help figure out at least one person. But please don't start with the squat nor the hinge. We love them, but aim for the lunge. It's a pretty amazing thing. Okay, we're out of time. I'm bummed because I've had such a blast, and we need to give away something. So I hope that you're ready on the chat box. I have it scrolled down, and I will definitely be so happy for the first person to answer this question correctly. You're going to get a $50 USD coupon. Dr. Folckomer, you'll email her afterwards, and she'll hook you up with a coupon worth $50 off an online course, which is, you know, our online courses are $300 USD. There are 15 hours of content, and we have some awesome files for you in our Facebook forum. And we also have us available to answer your questions anytime you want, as soon as we wake up. And we can't wait to answer them. So the chat box, if you don't know where it is very, very bottom of your Zoom to the left of the share screen that's in bright green. So get ready. Okay. Our question is, name the most powerful hip external rotator? Go. While we're waiting, and be specific. Oh, Joe Lee, gluteus maximus. Nice. So Joseph Lee, I am so impressed. Oh, we had lots of good answers though. Oh, look at all these answers coming in. Oh, that was so good. Oh, that was super fun. Joseph Lee, make sure that you email Dr. Folckomer at immaculateDissection@gmail.com. She will reply to your email. Just say, I won, Glute Max, right? And she'll send you your coupon. To explain the answer, I'm so glad that I didn't see a lot of answers that said Piriformis. I hope we scared the crap out of you guys at the beginning of this. That it wasn't. That's why I chose that question. Gluteus maximus is 25% attached to the greater trochanter, and even 25% of, gluteal tuberosity below the greater trochanter. And gluteus maximus, just 25% of it is larger in surface area than the piriformis ever thought about being. Piriformis is a joint centrator, just like the rest of the external rotators. Gluteus maximus can be a joint centrator with 25%, but the 75% of it attaches to the iliotibial tract and then down to the Gerdy's tubercle of the tibia, which is also called the iliotibial tubercle. And so it's the most powerful external rotator of your entire lower limb. It will always be the most powerful. And the other ones are just trying to center it up so it can execute its force generation. So 75% of gluteus maximus is force generation. It is the rump roast. It has amazing amounts of surface area and a very long tendon, making it a long lever. And physics was important. Hopefully you paid attention in physics. If you didn't, I didn't as much as I should have. You want a long lever. Yeah, you don't dig your garden at the bottom of the hoe. You put your foot on it, you grab the top, and you push down as hard as you can on that lever. And gluteus maximus will be that powerful lever for you. Well, from the ID team, man, we are so happy to see so many of you folks turn out on a Sunday. So many of you guys, it's late for you in London. We really appreciate it. We want to thank you guys so much. If we did not get to your question this week, please save it, okay? Please save it. I'll try to write them down at the end here, but if I miss it, will you please come back and ask it again? I know, Gurinder, you had to do that. We didn't get to your question last time, but we made sure to move it up the chain this time. So come back with us next Sunday, 5 p.m. EST. Get your questions answered. And again, you'll have another chance to get a $50 off coupon for the online coursework. Anna, any last words that you want to share? Oh, let me unmute you. Sorry about that. I had you on mute. Go ahead.
That's okay. No, just thank you so much, guys, for joining us. And your questions are phenomenal. And, you know, please hold on to them if we didn't get to answer them, because they spark some really great questions. And I just see that Joe has just emailed with giant subject letters that say, I want Glute Max. So Joe, I'm going to get to that right now.
Joe, you are the coolest. That's awesome. And for the rest of you folks that answered correctly, we're just a little late to the game. Man, now you have practice in, right? So you're going to come back next week and get a chance to win your $50. Okay. Danny, any last words to share with us? Let me unmute you.
No, just again, another awesome round of awesome questions and whatnot. I think it gives a lot of just like mutual feedback in terms of what everyone's interested in, you know, what to kind of, you know, think about, talk about, so on and so forth. And it's definitely nice having everyone, you know, involved and part of things. So
100%. Karin, let me unmute you. Any last words for the amazing idealists of this group?
Oh, no, thank you for joining us, and you know, hope to see you guys again soon.
Thank you folks so much. You make our dreams come true. We love talking about this stuff. Thanks for joining the family. I will upload this onto YouTube tomorrow and share it on the Immaculate Dissection Facebook page, as well as the Immaculate Dissection Instagram. So hopefully you guys will go back and watch a playback if you want to hear everything again. If not, we so appreciate you being here with us, and we hope to see you at a future Ask Us Anything. Thanks so much.